Okay, I will go ahead and get started. Oops, I just hit the wrong button. So, today we're going to talk about actually GI examination 2. Well, that doesn't make very much sense, right? Because it should be 1 before 2. But I actually like this because to me it lets me emphasize the importance of the examinations we're going to talk about today. And they're often forgotten or avoided for good reasons. We'll talk about why in just a moment. So we're going to talk about the digital rectal examination. Maybe that's why the attendance is so low today, because they knew we would talk about these things. But also hernia examination. And I wrote up here that it's a cardiac examination. What? That doesn't make any sense. I'm not talking about the patient's heart. I'm talking about your hearts, okay? And what I mean is, in America, we often use the heart as a symbol for motivation, what's driving you, okay? And it's easy to take a history for the most part, not always, of course. But you get tested, your character and your motivations get tested when examinations are a little bit less desirable. In other words, I don't really want to do this examination, and the patient doesn't really want me to do it. Will I do what is best for the patient even when I don't want to? And that's what it means to be a professional. It's what it means to be a doctor. So let's talk more about that. So why do we do these examinations? So why would I even ask this question? Well, they're sensitive examinations. It's a sensitive part of the body, right? And the patient may not want you to do the examination. And in truth, you may not want to do the examination. But that's okay. Sometimes we do things not because we desire to do them, but because they need to be done. They must be done. And, why would I say that? Well, what are some problems you might uncover by doing these examinations? What do you think? Why might we put our finger into someone's rectum, right? It's a shocking, stark kind of topic. So how about cancer? Might you find cancer if you put your finger up someone's rectum? You might, right? Prostate cancer, rectal carcinoma, you might. And in fact, pretty recently I heard a story of a man who had bleeding from his gastrointestinal tract. So rectal bleeding, bleeding with his stool that he complained about, and he went to the doctor and they didn't find anything. He went to the doctor again, they didn't find anything. He went to the doctor again, they didn't find anything. They had done endoscopy, CT scan, blood work, and they had found nothing. 6 months later, someone finally did a rectal examination, and they found his rectal cancer. It was undiagnosed for 6 months, advancing every day, getting worse every day, because every doctor he had seen refused to put their finger up there. And there's no replacement for this test. I know you're like, isn't there some other way? But no, there's no replacement for this test. So why do I say it's a test of your motivation? Well, I want us to recognize that there are serious reasons to do it, like the patient may be at risk of harm or death. Cancer, pretty deadly, right, if we don't diagnose it and treat it, potentially. Gastrointestinal hemorrhage. Can you die from bleeding from your GI tract through your rectum? Yes, I have resuscitated many people who almost died from bleeding of their gastrointestinal tract. Also, it's a good way to probe for possible infection or abscess. If you have a pelvic abscess, can that be a life-threatening situation? Yes, if untreated. Sepsis and death result. Okay? So, there are good reasons to do it, otherwise we wouldn't do it. But I want to encourage you now, this is, again, not just about a physical procedure. This is about what motivates us as doctors and human beings. Are we motivated by the good of the individual? Are we motivated by what it takes to keep people healthy and safe and allow them to live? And certainly we all want to think about, or I always say we want to think about in every lecture I do, the fact that human beings are made by God. Right? Again, You guys, most of you guys in this class of people are going to be Muslim. I'm coming from a Christian background. At the same time, we realize human beings are a special, valuable thing made by God. And so we should pay attention to that fact as we think about what we need to do for them. It may not be what I want to do, but they are precious and valuable by virtue of the fact that they were created by God. So I should take care of them. And that's a work that is not just education. It's actually a spiritual thing that we have to come to and realize that I need to be willing to forget about what I want and what I need, even if my clinic's busy, even if I've had a bad day, even if I have difficulties at home, even if employees are causing me trouble, I still need to do what's right for the patient in front of me every time. Okay? And again, as a Christian, that's something we look to the example of Jesus. We see that he served people. He was a servant. He washed people's feet, even though he was the teacher, the highest one, the one with the most knowledge. And we want to do the same thing as doctors. And so you want to find those role models. For me, that's where I look. For you guys, it'll be different a little, probably. But that's what we want to be thinking about. Get in that mindset. And I'm going to proceed to talk about the technical aspects of just doing the procedure. But again, if your heart isn't right, you won't do this procedure. And people will be harmed. And that's a serious thing, right? So I always want to take a minute and talk about that, because I guarantee you, I've seen it many, many times here, and I've seen it many times in America. People will avoid doing this type of examination like the plague, but there are certain times you just have to do it. I promise you. It will come up more often than you want. Okay, so here's another thing. Don't tell me you've done a complete abdominal exam if you haven't done a rectal examination and an examination of the groin area. You haven't, okay? You haven't. So don't tell, you can say I've done a limited abdominal, I've done a focused abdominal examination, but if you want to say I've done a complete abdominal examination, a complete gastrointestinal examination, you have examined the groin area and you've examined the rectal area. Because the GI tract goes all the way through to the anus, right? So, anyway. Again, I'm just trying to enforce the fact that this is a really good idea to get comfortable with the fact that this is a part of examining patients for real. Alright, so let's talk about this procedure, which everyone really is dying to talk about today. So, obviously, preparation-wise, you start with consent. What does that involve? It involves informing the patient about the procedure. What are some reasons the patient may say, oh no, no thank you, I don't want that procedure? Why might they say that?
It's rectal examination.
What?
It's a rectal examination.
It's a rectal examination. Prima facie, in other words, at the beginning, we know that nobody wants that. It's true. But what are some other specific reasons they might not want it?
They're afraid it might be a bit hurtful.
Yeah, so pain. Pain, definitely. They're worried about that. Let me reassure you so that you can reassure them. This is not a painful examination for the vast majority of people. There are a couple of situations that are painful. So you need to tell them, look, this should not be painful. If it is during the procedure, you need to tell me right away and I will stop, because that is not normal. Okay? So it's not painful, I promise you. Okay? I'm 40 years old. I've had my prostate examination. I've done this examination numerous times. It does not cause pain. There may be a condition causing pain that you could exacerbate, but that's rare. And again, that's not normal, so you stop and reevaluate at that point if there's pain. What else? I mean, it's just embarrassing maybe a little, whatever. Personal hygiene hang-ups. I understand. I get it. We all get it naturally. We all understand why someone might not want this. But pain is one thing you shouldn't worry about. Okay? Anything else you guys think about? Okay. So consent, you want them to be fully informed. If they don't want it, I always say, okay, it's fine. It is your decision. I want your consent. Let me give you the best information possible to use to make that decision. So you should take pain out of the equation. It shouldn't be painful. It's not. It doesn't take forever. This is not going to be a 30-minute examination. No, it's a few seconds. In truth, it's not a matter of minutes even. It's a matter of seconds typically to do this examination well. Okay? So things like that. You want to let them know it's not painful, it doesn't take very long. I'll explain to you at each phase along the examination pathway what I'm doing and what's coming next so that you won't be surprised. You don't want them to be surprised, right? So you're informing them as you go along, and inshallah, they will give you their consent. Okay? Almost always. I've had a few people refuse flatly and they wouldn't let me do it, but that was because of them, not because of me. I was going to do it because I needed to do it, and I was explaining to them the reasons why. They do need to understand that there are serious things that could be happening that might be missed if we don't do this examination. They need to understand that. as part of the risks and benefits of the procedure. But it's a no risk, extremely, extremely low risk examination, right? Of course you're going to want a chaperone. Anytime you do this type of sensitive examination, you're going to want a chaperone. Plus, you might need an extra set of hands to hand you things. It is a procedure, sort of, very simple one, but you might want an extra set of hands in the room anyway. Plus, it just helps ensure the patient's comfort. And then, of course, confidentiality, privacy, yes. Obviously, this is going to be a confidential, private type of examination. You, the patient, and a chaperone, because it is sensitive. You want to protect their sense of decency, their sense of personhood as much as possible by taking care with their privacy. That's obvious. Okay, so positioning. Yes? Oh, please, no problem. So positioning. You want to begin the examination with the patient in this position. We call the left lateral position, or the left lateral decubitus position, we'll call it sometimes. The buttocks are at the edge of the examination couch, and the knees are drawn up to the chest. His heels are clear of the perineum, as you don't want anything obstructing the rectal area, the anal opening, but you do want the knees up to open up that area as much as possible, and this position works really, really well. It's not the only position you can use. Sometimes rectal examinations will be done during female gynecological examinations, so use that same lithotomy position. You can. Or you can have a patient lean over the table, stand up and lean over the table if they feel more comfortable with that. It works. They all work. This is just the standard position. Okay? So if there's a reason you can't do this position, there are other options. Okay. You start with, you've already washed your hands and you've greeted the patient, all these kind of things. You're going to put gloves on, clearly, with this type of procedure, right? This is not something you're going to forget, so I'm not needing really even to write that down. You do want to start every time you do a physical examination with what? With inspection, right? This is the first thing we do. We look. So you're going to inspect that perianal area. What types of things might you see in the perianal area? Sure. You could see ulcers or lesions of various types. You could see evidence of an abscess. You could see fissuring or breakage of the skin. You could see ulcers. If they have ulcerative colitis, it could extend that far. Now, Crohn's disease. You could see hemorrhoids, of course. That may be the most common thing you might see. And you want to know these things, and you want to make note of them and describe their position and whether or not they are the explanation for the problem the patient is having. Certainly, a variety of infections you could see, structural things you could see. In a neonate, in a newborn, you may not see an anus. That would be a significant finding, right? If they're born with anal atresia. So it doesn't apply just to adults that we're looking for cancer and severe infection and bleeding. There's an examination, the external examination part especially, that you're going to do at all ages. So we're going to lubricate the finger, okay? We want to make this as comfortable as possible for the patient. So we have the gloves on. This is where an assistant comes into play. They can go ahead and put some lubricant, petroleum jelly or a water-based gel on your finger to lubricate things. And the one thing you want to do initially, because you want to maximize their comfort, just put your finger near the anal opening to start. You may have to spread the tissue with your other hand, but just put your finger at the outside to start. Why? Because you want the patient to get ready, to get used to that sensation. Because most people are going to react and tighten up all their muscles, and it's going to be impossible with the examination. So you want to proceed slowly and carefully. So by doing that, you give them a chance to relax. I lubricate my finger. I'm putting my finger near the opening after telling them that everything looks normal on the outside or what I see on the outside. And I say, okay, now I'm going to apply gentle pressure, and we are going to apply gentle pressure only. And we're going to push our finger gently through the anal canal into the rectum. Okay? So it's just like this. The patient's on their side. I'm just applying gentle pressure to go in. Okay? Using this finger maybe to move tissue or to stabilize things, kind of like the drawing is showing. Yeah, I know the drawings in this section are a little bit like, ooh, but they're helpful, right? To understand what we're doing here. I don't have the model present, so. So we just, each step along the way, we tell the patient what we're doing and why, and what we're seeing, and we tell them what's coming next. Okay, now I'm going to apply some pressure and insert my finger. You tell them to relax as much as possible, but that's really difficult, right? None of us feels very relaxed at the moment of this examination taking place. But if they focus on it, they can relax, but that's why we go slowly. We give them time to adjust to things, get used to things, and relax as much as possible. Okay? So, where do we go next? We're actually going to perform an examination of anal area. The anal area is very short as far as length of tissue. Okay, so the first thing you're encountering when you go in is the anal area, and you want to know about the sphincter tone. How well is that muscle working? So you can tell the patient squeeze down like you're having a bowel movement, and you'll feel the squeeze of that muscle. Or they may in fact have spasm of the sphincter. The muscles may clamp down on your finger because it's just a normal reflex. Okay? So if that happens, just take a second, ask the patient to take a few deep breaths, and just say, it's okay, I need you to relax a little bit, take a few deep breaths, we'll go slowly. But that's what we're doing in this area. You may feel the beginnings of some internal hemorrhoids or a break in the tissue that may indicate a fissure or a split of the tissue. But you want to know, is the tone normal or not? Okay, some people with spinal injuries have reduced tone. Some babies with the spina bifida, say, would be an example of where the tone would be decreased. So you do need to assess that aspect of it. And if they have a spasm, just go slowly, just wait a second, have them take a deep breath, and then proceed. Okay? All right. So once you pass through the anus into the rectal area, there's a procedure you want to follow. And it's hard to get from still pictures. But every time you advance your finger, you want to take time and swipe to the right, or to the left in this case, sorry, clockwise and counterclockwise. You want to feel the entire circumference of that area at each level because you don't want to miss something. And if there's a lesion, you want to describe how far in is it and how much of the circumference of the tissue is involved. Okay? So you're always, every time you advance, you're feeling back and forth to see if you're noting any mass or other abnormality. Okay? Again, if there's pain, make note of that. There should not be. This is not a painful procedure. It doesn't feel, it feels strange, but it's not uncomfortable for most people. Once you've gone all the way around as far in as your finger will go, which isn't very far, right? You're not going, through the sigmoid colon, with your finger. It's a short distance, right? So you may have to apply some gentle pressure to get in as far as you need to feel all the structures of the rectum. And one of the structures you want to feel in men, of course, is the prostate gland. So where is that located? Well, on these diagrams, you can see it's anterior, right in front of the rectum. The rectum is going to go backwards in the body towards the sacrum and run along the sacrum before it turns into the sigmoid colon and curves to the left and then upwards, right? So when you get in there, you want to feel anteriorly in men for the prostate. And you want to assess, okay, how big is it? And you'll get a feel for, after you've done these exams, or maybe you practice with models, we have some in the lab, that give you an idea of what does it look like for a prostate to be enlarged, or feel like rather. What does it look like for a prostate to be asymmetrically enlarged, right? So the prostate is typically a symmetrical organ. It feels a little bit like a heart shape from behind, and there's a central sulcus, a median sulcus, and then two lobes that you'll feel, and that's what you should feel. And it should be kind of rubbery, like a ball, like a firm, ball. But you want to notice the consistency. Maybe it's really hard, like a rock, or rough. Okay, that's not normal prostate tissue. Just a few months ago, I did one of these in a clinic for Syrian refugees, and sure enough, he had pretty clear evidence of prostate cancer on the examination. One side of the gland was enlarged, and it was hard, like a rock, not rubbery and firm. There's no give to it at all, and it was rough. It wasn't a smooth consistency like it should be. So assess the size, the shape, and the consistency of the prostate. Note tenderness. So if they have pain at this point, that typically signifies pretty bad inflammation of the prostate. We think of prostatitis, inflammation or infection. It's usually infection of the prostate gland. That's quite painful. That's abnormal. You make note of that, and you stop hurting the patient, and you treat the problem. You've gotten where you need to with the examination. Of course, in females, they don't have a prostate, so that's not anterior. You're looking more at the GU organs, and so you're looking for the uterine cervix and that sort of thing, but that will give way much more, and so at that point really you're also looking for any other mass that might be in the pelvis, right? What other masses might you feel? I mean, certainly the appendix can sometimes cause an abscess, right? And that abscess may extend into the pelvis. Ovarian masses may. I've definitely had that happen with patients. Very sad situation when you get an ovarian mass that size. It's often a malignancy, a neoplasm rather. So, you want to describe anything you feel that's beyond the norm. It shows that you need to do these examinations a good bit whenever the timing is right, because you want to be familiar with normal, so when things are abnormal, you recognize them immediately. And it's not necessarily an easy thing to do. That's why we have these models, why we're going to practice these examinations, and you're also excited about that on the models, but better than in actual patients. We'll get used to it first on models. Okay. Anything else you want to say about the rectal examination? That's probably pretty good on that. I think the key factors are advance slowly and with firm, gentle pressure. You're not going to, you just advance slowly with firm, gentle pressure, and at each phase advance, a centimeter or two, and then rotate your hand, and then rotate your hand. You want to get, if you're going to do this, if you're going to do it, some people say, they put their finger, oh, I did it, I'm done, excellent, I did it. But no, you have, if you're going to do it, do it the right way. Okay, don't rush it. When I say don't rush it, it doesn't mean take 5 minutes, take 10 minutes. No, to do it right takes less than 30 seconds probably. Certainly less than a minute if you're going really, really slowly. But no, it's not a slow, lengthy examination, right? So 5 seconds is too short probably, but I guess that's my encouragement to you, is don't get so excited that you conquered your fears and actually started the examination. If you start, finish, okay? Gotta finish. Do it all the way. Do it the right way. We don't want to miss anything that may harm the patient. And so then we finish. You withdraw your finger, and you think, wow, that wasn't so bad. You examine the stool. So we talked about the patient's history in the prior lecture. What are they telling you about the color of their stool, consistency, that sort of thing? You want to know, is there blood on my finger when I withdraw my finger? Especially if you're concerned about GI bleeding. So if you have someone with unexplained anemia, even if they complain of no blood in their stool, you're going to put a finger up their rectum and check their stool for blood, okay? If they're mucus, if there's some concern about an infection or an inflammatory process that may be giving you blood and mucus, breakdown of the walls, you may not see blood. You may see dark black stool like the melena we talked about in the history lecture, but you may not see blood. It may look pretty normal. In that case, there's a test you can do. You can swipe some of the stool onto a card and test it with a few drops of developer fluid to see, is there presence of heme, it's components of blood, in the stool or not. So even if you don't see it, sometimes it's there. All right? And again, if we see that, we think of, we need more investigation. We need to think about what causes bleeding in the GI tract. And they're often very serious things we want to make sure we do a thorough examination of, right? So we're looking for blood. Even if we don't see it, we're still going to check for blood with these so-called heme occult cards. They're looking for occult blood, hidden blood. And then, of course, when you've done all those things, you breathe. I know how you guys think, because I know how I used to think. Before I had done a lot of these. It was still sort of theoretical to me. So yeah.